All right. So I'm Bob Kowalick. I'm a PT and went from private practice into helping other practices with revenue cycle management, which is not just billing. Billing's a piece of that puzzle. So we have two entities, one that we do it for you in and one that we help you do it for yourself. So that's the two different companies there. So I'm going to step back real quick. At the highest level, the easiest way to think about what we do in the physical therapy business, and again, I'm not talking about 100% cash businesses that never bill insurance, that don't see Medicare patients but see others for cash 100% out of network. So if you're that, none of this is going to really matter to you. That's the simplest form of revenue cycle. You do something, you get paid at the time that you do it. That's about the way that most of the world works, but not so much in healthcare. So what we do in the typical traditional practice models is physical therapists convert time into CPT codes, units, modifiers, and clinical documentation. So Mary just talked about a lot of the ways that you should be thinking about how you translate or convert your time into those things. What those things do for you is create potential revenue. Just because you've coded an encounter and done documentation and done the units correctly and the modifiers and used the right time-based rules and all this kind of stuff doesn't mean you're going to get paid. The purpose of your revenue cycle, and your revenue cycles cut across your entire practice. It's everything from verifying benefits to managing authorizations to credentialing to how you convert time into CPTs and units and all these things, patient registration, all these things are revenue cycle functions. They all directly impact how well and how easily and how cost effectively you're going to convert potential revenue to cash. So your clinical logic, your clinical experience creates potential revenue. Your revenue cycle functions convert that to cash. The third phase of what you want to always be doing with revenue cycle is making sure that you get to keep the money and that your post-payment audit risk is very low. And as Mary said, the quality of your clinical documentation supporting what you've coded essentially in your encounter ultimately determines that. So not sure why my thing's not moving. There we go. So we have three revenue cycle management objectives. They're universal for everybody that's in the revenue cycle business. One is get paid 100% of what your structure allows. Mary just talked about several structural things, but there are other structures, what your payer mix is, what kind of combination of in-network and out-of-network you are with your practice. Those are structural elements. You want to get paid 100% as quickly as possible, and you want to get paid as cost effectively as you can, which essentially means as efficiently as you can. So this is where we've really evolved over the years. We've been tracking time to the minute by billing task, 29 different billing tasks for about 10 years. So we have hundreds of millions of minutes tracked over millions and millions of claims. So we know with a high degree of accuracy what time distribution looks like, but even more importantly, what a really good, efficient operation looks like. How much time should it take to get a certain outcome? The outcome you want, all the money as quickly as possible. So in the past 16 to 17 months, what we started doing, we built a platform so that we could track we basically converted the biller's process, the biller's task into a business intelligence tool. So we're now producing data as the billers do their task, and every time they bump into something that is a time inflator for them and a revenue risk for the practice, we record that in the platform. It takes 3 to 5 seconds to record something, but we've been doing this now on every single claim that we've processed in about the last 16 months. So we're close to 1 million claims that we've put through this system. Over 50 billers doing this 8 hours a day, 5 days a week. and across practices in about 30 states. And I'm going to share that data with you here in a second. But at a high level, what revenue cycle management is about, and again, whether you do billing for yourself or someone's doing it for you, you are a revenue cycle management company. And this fundamental relationship is what this is all about. You have to create a condition which balances billing time demand and billing time supply. You want the variable should never be your outcome. You should always be getting all your money as quickly as possible. The variable though is going to be the time that it takes to do that. And the time that it takes to do that is dependent on the things that drive billing time demand. And I call that category of things revenue cycle complexity. It's kind of a black hole in that it's mysterious and hard to understand and quantify and all that, but that's what we've been doing now for quite some time. So for any given volume of claims or visits in PT, the complexity can vary by a tremendous amount, so that the overall time required to get the outcome that you're after could vary by as much as a factor of 10 times. And that's not a typo. So if you combine operational ineffectiveness and complexities with payer added complexities, and if you have the extremes of both of those things at the same time, the amount of time, which essentially is FTEs for your billing, is going to be very, very differently than somebody who's at the other end of the spectrum. Pretty simple payer mix, really effective at controlling all the revenue cycle functions. That's going to be a much more efficient operation. So I think we, at a very basic level, think about how much time it should take to get billing done in the context of the volume of billing being done. But the biggest variable is actually the complexity of the billing. And that's what we're really providing data on that no one is. So your revenue cycle complexity piece breaks down into structural and operational components. The structural are these things on the left, your practice model, as I mentioned, your payer mix, the systems that you use. On the operational side, it's all these functions that cut across an entire practice, all these things that happen day in and day out within your practice are the operational issues. The interesting thing about billing, and this is why we've gone down the path that we have, is all the revenue cycle functions and the systems, so the structure and the operations all directly impact the time that it takes to get billing done. Billing is the only piece of the revenue cycle process. It's the only function in revenue cycle that's true for. You can't put any other one of these arrows in the middle circle. Billing is directly affected by every other revenue cycle function that occurs and a revenue cycle structure that exists within your practice. And since that's true, we can use the billing process, if it's used really correctly, to understand the things that happen throughout the practice that cause complexity, that create time demand and make the outcome more challenging to accomplish. So what we found in this almost million claim sample so far is that about 30% of all claims have a measurable time inflation issue. So I say time inflation, you as a practice owner should hear revenue risk. Okay, 100% of the revenue as quickly as possible. If it's a time inflator in billing, if you take nothing else away from this, take this. If something is going on that causes the biller to have to spend more time than they should have, it is a risk to your revenue. Different things have different kinds of risks and severity, but they are all contributing to revenue risk. So about 30% of the claims have issues. We look at these in these three buckets. Practice operations create 78% of the issues by volume and 68% of the issues by time. Payers create 8% of the issues by volume, but 23% of the time inflation, and systems create about 14% of the issues. So this is your EMR billing software clearinghouse, but about 9% of the problem from the perspective of time. So this is interesting in that what this data means is that the typical payer created problem takes triple the amount of time to fix as a other type of problem, either in systems or practices within the practice operations. This is the way the problems that we've quantified break down by practice function. The biggest two problems neck and neck for competing for first place are patient registration related issues, and second is provider documentation and coding related issues. So the rest, as you can see here, you can read the chart, but the point to take away here is that things that contribute to challenges with your revenue cycle cut across your entire practice. Again, I said 23% of the time is by payer. So this is just a little bit of a more detailed breakdown of some of the other things and how they compare in terms of volume of issues and time cost, of the issue. If we just look at the payer issue specifically, about 60% of those problems are related to communications, phone calls, just general things that you have to work with the payer in order to get paid. Authorization misinformation is the second biggest thing. Not having claims and appeals and reconsiderations on file, and all kinds of other miscellaneous issues. But when we look at the average practice in the US today, and again, we've collected in 16 months now about 1 million claims in 30 states. So this is what we see, that preventable time inflation occurs in 30% of the claims. Really, practices that are very optimized for controlling all of their revenue cycle functions are under 5%. So the average is 6 times what I would say a quality practice operation is performing at. 25% of all of the issues we encounter are considered to be revenue reducers, meaning if it's not fixed, it will reduce your revenue. 55% by themselves, not fixed, will inflate your AR. By themselves doesn't mean they're going to reduce revenue, but they could still reduce revenue, but they are going to delay the payment. So, and 20% are kind of nuisance things that are easily fixed, and the claim can kind of move on and on its journey and go through whatever process is going to happen to it. This is a big problem. So this is just in my slice of the industry, quantifying all of this. We have, in our use case, in the last year, that now, because of these preventable issues, encountered almost 20,000 hours of time inflation with almost $600,000 in cost, $4.5 million in practice revenue that was placed at risk, $11 million in practice revenue that was delayed, which there is such a thing as time cost of money. So when you go from this 30% problem, which is typical, to a 5% problem, here's one case study of a practice that went through that evolution with us. At the same time that they were evolving operationally and controlling their variables much better, reducing the amount of complexity in the revenue cycle, they also grew the practice by over 100%. But there's a direct correlation between all of this revenue cycle complexity and all these issues and where revenue per visit is. And as Mary talked about, we want to make sure we have the highest possible potential revenue, but you want to make sure you're converting potential revenue to cash at 100% rate. And when you do that, and all of this complexity is whatever part of it is controllable and preventable is done, only then will you know what your revenue per visit really is for the payer mix and for the clinical logic that you convert to, from time into coding. So in this practice's case, revenue per visit jumped $17 a visit over this period of time by controlling these factors and decreasing the complexity. The cost of billing dropped 40%, and I won't bore you with all these numbers, but at this scale, 5,000-ish visits a month, $17 a visit gain, there was about a $7 million add to the practice valuation. So everyone should be thinking about optimizing their revenue cycle operations. You want the most effective performance with respect to that. And that really helps you accomplish your revenue cycle objectives, convert that potential revenue to cash, do it as quickly as possible, do it as cost effectively as possible. It does lower your cost of billing. It should. If you're working with somebody that, if you're in-house with billing, your biller will just have more time to work more volume. If you're outsourced to a typical billing service, they'll just make more money. But that's not how we operate. But we're a outcome-based relationship structure. So, but you want to make sure that before you start going down the path of changing your structure, negotiating, with pairs, and these are all things that should be done all the time. But going out of network, let's make sure that where you are accomplishing the revenue levels that are already available to the practice by not leaving money on the table. So, thank you for your time. Hope you found that interesting, and reach out to me at rmk@certifiedrsllc.com if you've got any questions or interest in how we might be able to help you.